Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing, we explore the critical and time-sensitive decisions around fertility preservation before cancer treatment begins.
Joining us is Dr. Josh Hurwitz, a board-certified expert in both.
I guarantee you, this time next year, I'll be doing something that I've never heard of right now, and I just love it.
We all need to know a lot more about. I am sorry you really have this really bad cancer, and by the way, were you ever planning to have children?
Who do you get the most referrals from?
Once they meet you, what's that timeline course like?
As soon as I get a referral in for a cancer patient, for a fertility preservation patient, we will see them within 20.
Is there an age that's too young or too old for you?
What's a typical cycle look like for a patient?
There's also a growing movement in reproductive medicine that even if someone does have a partner, that maybe that person should not intertwine.
How many cases in court have you seen over frozen embryo?
What should we be saying to our patients about being able to preserve their eggs?
We have to take care of their survivorship issues as taking care of them as whole people and not just treat them as cancer patients.
This is Carla, Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing. When a breast cancer diagnosis enters the exam room, fertility often exits the conversation. Yet for many of our patients, a cancer diagnosis also threatens their future dreams of building a family. In this episode, we explore the critical and time-sensitive decisions around fertility preservation before cancer treatment begins, as well as options for family building after cancer. From egg freezing to reproductive counseling, this discussion will offer you insights to better guide your patients through the intersection of survivorship and reproductive hope.
Fortunately for all of us, we don't have to navigate this topic alone today. Joining us is Dr. Josh Hurwitz, a board-certified expert in both OBGYN and reproductive endocrinology and infertility. Josh is incredibly accomplished. He serves as the Director of Fertility Preservation for the Nuvance Health Network and leads the Division of Reproductive Endocrinology and Infertility at Danbury Hospital in Connecticut. He's a nationally recognized educator and researcher and has authored numerous publications on these very topics. He's presented his work at leading national fertility conferences, and with a deep clinical expertise and, more than that, an incredible passion for teaching not just his colleagues but our patients, he brings a vital perspective to this conversation about fertility in the context of breast cancer care. Josh, I am thrilled to welcome you to the Next Breast Thing podcast.
Thank you, Susan and colleagues. I'm really excited to be here. I have a real passion for getting the word out about the fertility preservation for men and women with cancer, and I'm really glad to be here. Thanks.
So before we dive into the topic today, I've always been interested, and we've had numerous conversations over the years, but I really never have asked how you got into this. We all have our story. How did you get into this, and specifically this field of frequently dealing with cancer patients?
Growing up, I always knew I was going to be a doctor, like a lot of us did. That didn't seem like a choice to me. Felt like a calling. Somehow I fell in love with OBGYN, not thinking I was going to be there. I definitely thought I was going to be in a surgical subspecialty, but had such a great time on my rotation. I really fell in love with women's health and OBGYN. I think I like the immediate decision-making, the combination of surgery and getting to know your patients. In residency, I knew I was going to do a fellowship. I know in my bones I'm supposed to be doing what I'm doing. REI, reproductive endocrinology and fertility, it's at the bleeding, cutting edge of science. I guarantee you, this time next year, I'll be doing something that I've never heard of right now, and I just love that. It suits my personality very well to give somebody something good rather than maybe take away something that's bad. I just know that that's me.
I loved your story, and I think we probably all were thinking it's very similar to why we became breast cancer surgeons. We love operating, we love the relationships, and we love how fast technology and science is changing. So I've really been looking forward to this episode. I know our listeners are going to be thrilled because this is a topic that we all know, some maybe more than others, but we all know a little bit about, but we all need to know a lot more about. So I'm really looking forward to hearing a bunch of things. I'm going to try not to ask all the questions, but I think our listeners are going to be excited as well.
I guess one of my first questions is, as surgeons, we are typically the first stop for a breast cancer patient, male or female. Who do you get the most referrals from regarding fertility preservation for cancer patients?
I get most of my referrals for breast cancer patients from breast surgeons. I think that makes sense. Susan, you and I have shared many, many patients over the years, and you and your colleagues. I find that those are the most immediate and the quickest. By the time they get to the medical oncologist, they've been in the system for a while. Their treatment path is settled. There's a tempo to their treatment and like deadlines that they have to hit. So I do get patients from medical oncologists for sure, and especially for other cancers besides breast, so Hodgkin's, non-Hodgkin's, colon cancer. But I would say I get my most immediate referrals, my quickest referrals up front are from the breast surgeons, which I really appreciate.
And does that help you having that extra time from having that couple weeks extra from the breast surgeon for the referral from you? And what does that mean for a patient in terms of once they meet you, what's that timeline course like?
The timeline is very tight. A lot of people are doing neoadjuvant. It's my job to get them back to you and the medical oncologists within 3.5 weeks of me seeing them, because I don't want to wreck their timeline. That's not at all what I want to do. In the old days, 8 years ago, 10 years ago, the old days, we used to do surgery more and then have that lull in between, like 6-7 weeks in between surgery and chemo. And that's where we would do our fertility preservation procedures. Now, the young patients, again, I'm talking out of my depth. This is what you guys do every day. I see more and more neoadjuvant. It's rare when people are doing adjuvant in my life. And so I have to hurry up and get them back to you. So really a week makes a big difference. So I often tell people, I'm sure you see it themselves, they're going to go for second, third, fourth opinions. I said, listen, do not get trapped into the paralysis by analysis. You've got to make decisions. You've got to move forward, but let's do your fertility preservation right now, because whoever you go to, they're going to want this done. Even a week makes a difference. So the timeline, Susan, just to answer your question a little bit more directly, as soon as I get a referral in for a cancer patient, for a fertility preservation patient, we will see them within 24 to 48 hours. Weekends, nights, mornings, 5 o'clock in the morning, Sunday mornings, whatever it takes. We have to get them in. We have a whole fertility preservation team in our practice because we do so much of this, and it's something that me and our entire team and all my partners are really, really passionate about. When we see them, spend about 45, 50 minutes with them discussing what we have to talk about, which I'll go in a little bit more detail in a bit. Then I have to get them onboarded to the practice. I need to check their ovarian reserve through a hormone called AMH, an ultrasound to measure their ovaries and their follicle counts to gauge what dose and protocol to give them and what their baseline is. And then it's my job really to get them on meds within a week of meeting them, because it takes about 2 weeks from beginning of medications to retrieval. So I can get them back to you in about 3.5 weeks. I always feel like that's my job. The last thing I want to do is hold anybody up.
So Susie, in your practice, what would you say your biggest obstacle to fertility preservation for your patients is?
For us, we don't have one that is right next door to our hospital. So we have also established really good connections with people that we know will get these patients in. And they are so responsive, and I'm grateful for that. And I think one of the biggest barriers is having that conversation immediately. I am sorry you really have this really bad cancer. And by the way, were you ever planning to have children? I mean, it's like a lot to handle all at once. And then saying, oh, just in case you wanted to have kids, this is what we need to do first. And it is a crazy conversation because we're not talking about cancer for a minute. We're talking about the rest of their life and how can they be there for the rest of their life. I mean, it's a lot for them to handle. So I think that's a big barrier. I would definitely say that our biggest challenge is the providers. So, Josh, from your end, I mean, obviously you're seeing patients quickly and practicing in a certain area. Is there discussion that there's more of these providers that are needed for oncology patients? What does the market or sort of the training look like for what you do?
REIs, there's probably only about 1,100, 1,200 of us across the country. They're mostly bicoastal, like everything else. And so there are definitely deserts of care in the country. People need to travel a little bit. Everybody who trains through REIs can do this. It's a 3-year fellowship after a 4-year OBGYN residency. You just have to have a passion for it. And you really have to set up your protocols and your team for it. That's really what you have to do. So we know it's a fire drill. When I get a call from Susan, I'm like, okay, drop everything, get this patient in, let's get moving. And multiply, you probably get about 4 to 5 referrals a week from different places, breast surgeons, medical oncologists, things like that. So you really have to have a great team, which we do. And it's not just the doc, it's not just the nurse. These patients are overwhelmed. They're dealing with that same psychological double blow that Susie talked about. Oh no, I have cancer. And oh my gosh, might not have children. That just paralyzes people. But also financial counseling, that's a really important part of it. And then there has to be communication between me and their oncologist, whether it's surgical or medical. Hey, what's their plan? Do I have your clearance to go forward? Are they okay? Do they have any other medical issues? Do you need to do something before I can do something? Things like that. So you have to have a team in place. I think there's enough of us REIs around the country, but in some places you might have a little bit more problem for the patients. They might have to motivate to go a little farther.
Josh, does reproductive endocrinology differ for a cancer patient than it does just from someone else who is unable to get pregnant, other than the time-sensitive manner?
That's the biggest part of it. Another part of it is that all the things that we've perfected over the last 30 to 50 years, eking out every percentage point in IVF cycles to help people freeze eggs or freeze embryos, that goes out the window when you have a fire drill. We have a sequence of events to get people ready and prep them and get everything started and do it in a certain sequence. IVF is best when you start at a certain time of the menstrual cycle, usually at a lull, at baseline, at the period, where you've got some pre-cycle suppression, where you've lined up all the follicles at the starting gate together. I can't wait 3.5 weeks for the patient's period right now. So we start them randomly throughout their menstrual cycle. And a lot of advances in the IVF world, in the REI world, have come from oncofertility. What we're doing for egg freezing right now is called vitrification, as opposed to the old slow freezing methods. Slow freezing 12 years ago, 15 years ago, you'd get crystallization, you'd get spindle fiber disruption. You wouldn't do well with a frozen egg. The frozen eggs were not good to freeze. But a lot of people did a lot of research into vitrification. The technical definition of vitrification is going from an aqueous cell to a crystalline frozen one, a glass-like solid without passing through any crystallization. So we do fast freezing protocols or vitrification that has revolutionized egg freezing. It is basically a fresh and frozen egg are basically the same. That's why you see so many people doing elective egg freezing as well, which we might touch upon later. And also that has revolutionized embryo freezing because they do better with vitrification as well. So a lot of this research that a lot of people put into helping men and women with cancer has really raised the tide for all of IVF and all of REI. It's been fantastic. So other things that differ, patients might be sick. If you have a stage 3 or 4 Hodgkin's or non-Hodgkin's patient who's really sick, that changes things a little bit. Also, there are some reports about 8 or 9 years ago that patients with cancer have poor outcomes through IVF just due to their cancer. Their body might be fighting it off, so to speak. That is under question right now, and there's some subsequent papers that don't say that. I think the sum total is everything we do to get people ready for a standard IVF cycle. Since you can't do that, you have a little worse outcome in the cancer world, but not enough that it's demonstrably worse.
Can I ask a question about the timing? We talked about sort of the difference between elective and cancer is the timing. When we talk about this, a patient gets a cancer diagnosis, we're moving forward with chemo, we're moving quickly, surgery relatively quickly, but there are some cancers where we might have a little bit more time. I wouldn't say we're sort of sitting around, but can we differentiate that at all? Or sort of are most of these patients pretty urgent just because they tend to be younger women who tend to have more aggressive cancers? But are there ever women where you say, hey, look, she's young, she's got a small ER positive breast cancer, we're going to do surgery up front, and we can potentially wait those 2 weeks until she's starting her period? I mean, how often is that coming into your decision making?
Great question. I'll say that we probably can do both. What I mean by that is we hurry up and do the fire drill and start their first cycle. But then I'm actually sharing a patient right now with Susan's colleague who has a very low oncotype, has a very early cancer, very low ERPR. And she said, hey, look, she's not going to do that well in this first cycle. We told me her egg retrieval is not that great. Do you want to do a second cycle? Because it's even under question about whether we're going to start chemo right away or not. So we can sometimes sneak in a second cycle. Susan and I have shared patients where I've been able to sneak in a second cycle. I'll be honest with you, most of the time we cannot. Stage 3 breast cancer, you want to get them started, things like that, things you know better than I do. So you get it on the back end. Say, hey, look, let's sneak in a second cycle, because don't forget, I'm sometimes seeing them so early, the oncotype might not be back yet. They might not be fully staged. So I'll be told by my oncology colleagues, Josh, just hurry up and do your cycle. We'll deal with their treatment on the back end. So I don't know what that's going to be. We just have to hurry up no matter what, I would say. And then if we get a little bit more time, maybe 1 out of 20 cancer patients, the oncologist will let me do a second cycle if they don't have enough eggs or embryos.
So Josh, one of the things that I've heard from oncologists over the years, probably over decades, and I've never understood it is, oh, that woman's 30 years old, she doesn't need to see the reproductive endocrinologist and she'll get her periods back. Well, periods and fertility, two different things. First of all, is that true? Is there an age that's too young or too old for you?
If I could just maybe sharpen up that question a little bit, what are the prime time ages for referring a patient that you see to a reproductive endocrinologist for counseling? So I would say anybody in the reproductive age group, everybody deserves to be counseled. Even if they elect not to do fertility preservation, they need to know what they're up against. So I would say that's anywhere from whatever young age you would see to 45, pushing it a little bit, but I think those are fair game. Men also get chemotherapy for other things. They can freeze sperm as well. So that can be at any age, of course. Now, on the young end, let's just touch upon this for 1 second. I'm not sure this is a big part of your practices, but I do see there are really young patients with other cancers. So there are things that we can do. It's really hard to cycle a patient who's in her early teens, like a tween. That's really hard. We do it, and we have done it, and we will do anything to help a patient who needs it. But let's say someone is prepubertal. You cannot freeze eggs or cycle someone who's prepubertal. So just for the scientific part of this, there is a newer treatment where you can laparoscopically harvest cortical ovarian strips. So in an ovary, the outside cortex has all the follicles in it. So you take these little strips and you can freeze them. You can slow freeze them, actually. They're not vitrified. And then they actually, in practice, can be reimplanted into sort of like the ovarian fossa, or if there's an ovarian nub, or in the pelvis, or you can actually do it xenotopically as well. And that actually can function. They can have reproductive function. People have gotten pregnant through that. That's a very specialized thing. That's not sort of clinical REI like I do. That would be big city referral to like an academic center. In Europe, they do a ton of it. I will tell you that there's probably about 300 babies born in the world from that technology. So it's not experimental anymore. The experimental label has been removed from that. It's really probably for prepubertal girls, I would imagine. Although in Europe, they do that more than egg and embryo freezing for whatever reason.
My mind is going,
Unbelievable.
I know. Yeah. It's crazy. 300 little ones out there from that.
You should see the videos too. They're really neat. Like the surgical videos, they're really cool.
So who pays for this? This is always the question. You talked about financial counselors. You just talked about a really cool, unique procedure. But for the average patient, is this all covered by insurance?
Great question. I can talk about my experience, and then I'll talk about what I hear from the rest of the country. All right. So Connecticut, I'm going to toot our horn, first state in the country to pass legislation at the state level to mandate commercial insurers to cover fertility preservation procedures for men and women with cancer. It's called Melissa's Law. Melissa was a patient of mine. She and I went to Hartford and we lobbied, and I was very underwhelmed by our state legislature, but that's another story. And we got that passed in about, I think, 2019, January 1st, 2019. Rhode Island became the second. Massachusetts was close after. New York, where Susan primarily practices, was the 6th state in the country to require that. So there's about somewhere between 6 and 10 mandated states right now, as of the last time I looked, that require commercial insurers to cover it. Now, there's a million loopholes, but that's a good start. However, state-sponsored plans and all the federal programs, they do not cover any fertility-related procedures, including fertility preservation for men and women with cancer. So if there's no mandate, there's a very good chance that it is not covered in the rest of the country. Egg freezing cycles, I'm just going to talk about Connecticut, not like Metro New York or Metro LA or something, which are much more expensive, but 10 to 12 grand all in meds, storage for a couple of years. And we don't charge storage fees for people with cancer. Now, what's an important thing I want to mention is an organization that we all know called Livestrong. They are very dedicated to fertility preservation for men and women with cancer. And if someone does not have their own insurance or can't pay for it, they get the meds from pharma for free. We do the cycle at cost. And so an egg freezing cycle is more like $5,000, an IVF cycle is more like $7,000, give or take. I hate to talk money, exact dollars. That's about what our costs are. I can't speak for any other practices, but I feel like we're on the lower side, to be very frank. That's a great program, like $5,000 for an egg freezing cycle. I mean, it's a lot of money for a lot of people, but it is a manageable amount of money.
Well, first of all, congratulations on being such a leader in the community and having a pathway that other people can follow. What does that look like for a patient? Sometimes our patients go, what does that mean? I'm going to go down, I'm going to have this 50-minute consult, and then what? What's a typical cycle look like for a patient?
As we all know, a woman ovulates 1 egg and 1 follicle per month. That does not cut it when it comes to egg freezing or IVF cycles to make embryos. We want as many as possible. So really 10 to 15 eggs is what I'm shooting for. So the patients will take 1 to 2 sub-Q shots per day. These are recombinant gonadotropins, or recombinant versions of FSH and LH, not a crazy chemical, natural hormones, recombinant versions. And it's 1 to 2 shots per day for on average about 10 to 12 days. So we teach the patients how to mix and take their meds. Now, while 10 to 12 days is the average, they can stimulate as little as 8 or 9 days and as many as 15, 16 days. There's big variation. So we need to monitor them very carefully. So the patient experience, Susie, is what we call a morning monitoring visit. So almost every IVF center in the country has these early morning hours that start at like 6:30, 7 o'clock in the morning. That's where I show up for work every day. And I'll do like 30 ultrasounds before I start the rest of my day. And we're doing transvaginal ultrasounds. So that could be a problem for some patients. And we're doing blood work to measure estradiol and progesterone and LH levels. And what we're doing is we're trying to see how many follicles are growing, how fast they're growing, and pick the most fertile day to trigger the ovulation for that particular patient. It's very precision medicine. It is very personalized and unique to that patient. It's not a generic day for everybody. On that day, they take a different shot of medicine called the trigger shot, which mimics the LH surge. A little extra oomph to it, but that's basically what it is. 35 to 36 hours later, the timing is critical here. They have an egg retrieval. Short, minor surgical procedure they do in my office. They have to go to the hospital. Propofol sedation, which everybody loves. Full night's sleep in 20 minutes. Eggs come out of the body through the vagina. No surgery through the abdomen at all. Just a Band-Aid for their IV, but none on their body. Easy. So we get eggs. If we're going to freeze the eggs and just plain eggs, and we'll talk about who should freeze eggs and who should freeze embryos maybe in a second, they're frozen on that day of the retrieval. The patient knows how many she has that day. Instant gratification. She's done. I usually text their referring doc and say, okay, Dr. Medical Oncologist, Dr. Breast Surgeon, they have the retrieval, give them a day or 2 to recover it. They're all yours. Done. That's what it is. So we get to know our patients a lot in a very short period of time, right? It's very intense, but short. And I love to, give people the fist pump and hand them back to their team. Now, if you're going to freeze embryos, we need a sperm source. And so that person, that partner, that sperm source, donor sperm, if you're thawing that, would be thawed, or we would use the sperm to fertilize the eggs on the day of the retrieval. The embryos then grow for 5 to 7 days in the lab, where the strong ones make it and the weak ones poop out. So it's like survival of the fittest, where the strong ones self-select themselves. Big drop off. So on average, about 12 eggs, on average, about 3 to 4 embryos. Depending on the age group, each of those embryos represents about a 50 to 60% chance of a live born baby. So it's pretty obvious that if someone is unpartnered and they don't have a sperm source, they should freeze eggs. There's also a growing movement in reproductive medicine that even if someone does have a partner, that maybe that person should not intertwine her future fertility with somebody else's. Because if something happens to him or they break up and she doesn't have any more egg reserve left after chemo, right? If her egg supply is cooked, then she's kind of stuck with those embryos. So maybe even if you're in a committed relationship or a permanent partnership, maybe you should freeze eggs and not intertwine your future fertility. I've had plenty of patients who come to me with 2 kids, the love of their life, they've been together forever, and they just maybe want one more later on after cancer. They don't know. They should freeze embryos. That makes sense. Embryos, a little bit more hardy to freeze and thaw than eggs. And that's why this perpetuates itself. Patients come in, I heard embryos are better. Should I make embryos? Well, not with this guy you just met on like swipe right last night. No. Fresh eggs and frozen eggs are almost identical. Fresh eggs are still about 10% more efficient than frozen eggs. That's basically the endpoint. So we do like eggs to maintain reproductive autonomy. That's the fancy term we use for it. But embryos are definitely more of a sure thing, hardier freeze and thaw, a little bit more risk certainty on the back end.
I have a question now. How many cases in court have you seen over frozen embryos?
Yeah, I read about the fancy one. I don't want to say her name, the actress, and that guy, right? That's the famous one. I don't really see it because it's ironclad that she can't use the embryos without him and he can't use the embryos without her. It's ironclad. It's in the documents. I have not in my career been involved in a lawsuit about that.
So it is in the documents when the embryos are created.
So when you sign consent forms, that's part of like the onboarding process. The consent forms talk about if I die, I want my partner to get custody. If he dies, I want the custody too, or we want to donate them to research or we want to discard them. That's in the consent forms.
Okay, Susie and Carla, did you know that? Because I have a patient, and it was a long time ago, who was involved in a court case over this. Did you know that that was in the legal documentation?
So I did because I had to sign it.
You're just smart.
When I went through. No, it's because I went through it. And I'm like, oh man, if I was younger, this is like new and great right now. But my question, Josh, is do you have some women who are like, hey, I'll do the embryo thing, but can you save a couple eggs on the side just in case? Is that allowed?
Absolutely, yes. And I love doing that. There's only one problem. It makes no sense to freeze less than about 10 to 12 eggs total. And it makes no sense to fertilize less than about 8 to 12 eggs for insemination to make embryos. So that means that that person has to be an especially large responder, very high responder to IVF to have about 20, 25 mature eggs to split them up half and half. Because what you end up doing is you try and compromise and get both, you get neither. So you can do both, and I've done both in both elective cases and in cancer cases, but it gets tricky because the reserve has to be especially good.
I can't even imagine walking with 20 to 25 follicles like ready to come out. I think it would be like really, really tough.
Yeah, the numbers behind it is that any given frozen egg probably has no better than like a 5 to 10% chance of being a baby. That's why there's strength in numbers. Because if you think about it, it's about an 85% thaw survival, about a 60% fertilization rate. About half of those will make embryos, and each embryo has about a 56% chance of a baby.
A lot of numbers. And I like numbers.
Is about 5 to 10% of eggs. That's why you really want about 10 to 15 eggs. Now, the less well-known secret of egg freezing, both elective and in cancer patients, is that the older you are reproductively, the more eggs you need to accomplish the same goal as fewer eggs as a younger woman. So 12 eggs at 34 is the equivalent, honestly, of like 20 to 30 eggs at like 40, 42, right?
Wow. Can you just touch on the success rates based on the decade or however you think of it? Our patients are freezing embryos and then going to IVF or freezing eggs.
If you use fresh eggs and you make embryos, you get 12 eggs, you make 3 to 4 embryos, you have 3 to 4 chances of 50 to 6% chance of a baby. It's something that I really make sure people understand is that this is not a guarantee of a future baby. This is not a insurance policy of a future baby. This is risk reduction of not having a baby by as much as we have to offer in medicine. It's a really important concept to get across. Now, if I could offer someone who's going to get life-saving but life-altering chemotherapy, 5 to 6 chances at 50 to 6% of a baby, yes, please. Now, you're doing both of those things just in different sequences. If you use fresh eggs, you get 3 to 4 embryos, you know how many chances you have at what percentage. And I'm quoting you my numbers. I don't know what nationally or what your centers would be around the world, around the country. Now, if you're doing egg freezing, you're doing the same thing, but you're taking the risk on the back end. So you're just freezing eggs. In the future, when you come back to use them, you're now thawing them, fertilize them with your future sperm source, and then making the embryos. They have to make it all the way to the embryo stage again. So the difference is you've got an 85% thaw survival for eggs instead of a 97% thaw survival for embryos. And like I said, frozen eggs are about 10% less efficient at making blastocysts, the final stage of the embryo, than fresh eggs. So I'm supposed to say fresh and frozen eggs are exactly the same, and they kind of are. When you have a lot of them, you get what you want either way. But let's just say you get 12 frozen eggs and someone who's 35, and she comes back to me 5 years later after chemo, surgery, hormone suppression for 2 to 3 years, something like that. And she's 40 now, can't make new embryos because number one, she's 40, number two, she had chemo. And let's say you thaw those eggs and let's say 9 survive, let's say 6 fertilize, and let's say 1 or 2 make it. That's a different story. But you didn't know that 5 years ago when you could have cycled again. So you're taking the risk on the back end when you can't fix it. Now, that risk is this much versus this decrease in your quality of life if you have to pick a sperm source before you're ready. So you bet against this one, not against this one. But success rates are awesome. Once you get to the embryo stage, the pregnancy rates are great. Modern IVF at good IVF centers should be 50 to 60% chance of a live-born embryo per embryo. Stop. Full stop, period. Now, it goes down with age, especially if they don't do aneuploidy screening of embryos, which we can also do. We haven't even talked about that yet. But it should be about 50 to 60% chance per high-quality embryo. Once you get to the embryo stage, the pregnancy rates are exactly the same between fresh eggs and frozen eggs. That's what I probably should have answered a little more succinctly. Sorry.
And Josh, we're running out of time, but I just wanted to touch briefly on elective egg freezing, because there's so many of our listeners that are questioning this for themselves or for their young adult children. Where do we stand on this? When does it make sense? Does it always make sense? Does it never make sense? What are your thoughts?
I think it always makes sense. It is a super empowering thing to do. And if someone is anxious about their family building, they should do it. It's a really amazing thing that we can do now for patients. So prime time, just in the interest of time, prime time about 30 to 36 years old for egg freezing. You can do it younger. The younger, the better. However, 26, you're so young, you might not need them. Could get 3 babies before you're 35 and never needed to go through the whole thing. So we don't recommend it for those young patients. After 38, the quality goes down so sharply that you need so many more eggs that the efficacy of egg freezing goes down. Doesn't mean you can't do it. And I have absolutely done it for women who are older, both cancer patients and electively. There's a phenomenon out there when people get divorced, they make 2 calls. They call a divorce lawyer. They call us to freeze their eggs. It's like a thing these days. Yeah.
My burning question is, how do you counsel patients who come in and say, this is all great, but am I going to pass cancer on to my baby? Or is my child going to be more likely to have this? How do you handle that?
So the genetic mutations, heritable like BRCA, Lynch, all the other ones, once you make embryos, Susie, you can test the embryos with over 98% accuracy to see which ones carry the dominant or recessive mutation and which ones do not, and deselect them for transfer. That's called PGT, pre-implantation genetic testing. We do that all the time for non-cancer conditions, cystic fibrosis, Fragile X, spinal muscular atrophy, all of it. We also do it aneuploidy screening. So as women get older, quality of eggs goes down due to the biological clock. You get increased risk of Down syndrome and misaligned chromosomes in the embryos. So we can screen that. So we can do all of that on the back end. Now, directly, if a patient really wants to ask, did my germ cell give my baby cancer? The answer is no. But heritable diseases, we can absolutely screen out. We do PGT for aneuploidy screening every minute of every day. We can just add in like a BRCA gene or whatever it is. This counseling is a little bit more work to it. I just want to finish up what Susan asked me about egg freezing. So elective egg freezing has 3 main benefits for anyone out there, especially women in medicine. I give this talk a lot. It's called Don't Put Your Eggs in One Basket. That's what I call the talk to women in medicine groups. So it stops the clock. Whatever age you freeze them, you will have those eggs for the rest of your life. So your future pregnancy rates, miscarriage risk, Down syndrome risk, they will be based on your age when you freeze them, not your age when you come back to use them. Number 1, stops the clock. Number 2, maintains, I'm going to use this term again, reproductive autonomy. No sperm source. That's why they're coming to us. And 3, it takes the anxiety out of their lives. They go to sleep thinking about this. They wake up thinking about it. Cross this off your list. And then a lot of my patients also tell me it actually improves their dating life because they feel this tremendous pressure in any early relationship to hurry up and have a baby because their clock is ticking. Like, how many times can I have a glass of Pinot Gris with this guy and not think I need a sperm tonight because my clock is ticking? That's not healthy for a relationship. But all my patients tell me that. I'm telling you.
No, I mean, you hear the term all the time. My clock is ticking. It's a real thing.
So I wanted to just jump in really quick because I know we're finishing up. You're talking to breast surgeons. What should we be saying to our patients about being able to preserve their eggs or embryos, as we talked about?
Sure. I think patients are scared, and they're scared if they take a minute out of their treatment path or if they have extra hormones in their system that they're changing their prognosis for the worse. And I think it's our job to let them know that all the research out there has shown that taking a month off and even having a pulse of hormones will not affect their prognosis at all. We know that. The other thing I would just mention, and we haven't brought this up, is that in IVF cycles, estradiol rate levels are going to be supraphysiologic, but we attenuate that. For every hormone-sensitive cancer, we layer an aromatase inhibitor on top of it. So I keep estrogen levels at physiologic levels. Progesterone, for PR-positive patients, that can't really be attenuated, but it's mildly supraphysiologic, not crazy supraphysiologic like estradiol levels are, and it's only for about 10 days. And from the medical oncology world, I can't speak for the breast oncology world, we know that taking the time out and having that pulse of hormones does not affect future prognosis and survival. I would like you to let your patients know it's not scary, it's not going to hurt your chances, and I don't need to tell you, you're on the front lines of this, but early onset cancers before the age of 50 have increased like 40% in the last 20 years. And the biggest increase in those have been in women. You don't need me to tell you that. You live this world. And so everybody deserves to be counseled. Everyone's going to be faced with this. And you and your colleagues, as well as our medical oncology colleagues, are so good at your jobs these days. And survivorship is so good. You guys are so good at treating patients these days that we have to deal with survivorship issues. We're going to have them for a couple of years, but they have to live their entire lives. And thanks to you and your colleagues, they can. But we have to take care of their survivorship issues as taking care of them as whole people and not just treat them as cancer patients.
I have to say, every time I talk to you, I learn something. And more than the educational aspect, it's really so inspiring to speak with you. We learn, we have a whole new renewed interest in making sure that every single patient has this discussion and the opportunity to freeze eggs, embryos, or just be counseled in that. So it's an absolute pleasure to have you on our special episode. I appreciate you being here. I appreciate how you take care of all of our patients and what you do for the field in general.
Thank you for your kind words. This was fantastic. I love getting the word out. You guys are great. This was a lot of fun.
To our listeners throughout the entire breast community, we're so excited once again that you've joined us on this journey, and we will see you next time on the next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie.
Michael.
Susie.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.